Hi everyone, this is Alina Isaac. Today we are starting the first session of the advanced module in ID Forum. We are so glad that we have been receiving a lot of positive response and we are so much overwhelmed with the good feedbacks from for our basic modules. A very big thank you to all of yours for your constant support and appreciation. So this actually motivates us to bring more and more valuable and advanced session. So, for today, let's get started. And it's my pleasure to introduce today's speaker, Ms. Krishna Suresh, a clinical pharmacist in infectious disease and antimicrobial stewardship program in KIMS Health Trivandrum. So she completed her master's in pharmacy practice from Government Medical College Trivandrum, and she hold an certification in antimicrobial stewardship from Manipal Academy of Higher Education. So she also have done wonderful research in self-reported beta-lactam allergy, mislabeling, inappropriate antibiotics use. She's also an active member of FCPI, and she was one of our good speaker in ID Congress 2025. She have done wonderful work in urine culture optimization in EDs, and her poster was presented at the Shia Spring Conference in 2025. And what more to add, she has also presented at SIT's AMS subcommittee meeting. So we're so proud of her, and it's my privilege to introduce her for today's talk. So today she'll be speaking on the topic community acute pneumonia. So without any delay, let me warmly welcome our today's speaker, our eminent speaker, Miss Krishna Suresh, to begin. Thank you.
Thank you, Alina. Thank you for that great introduction and welcome. So I am very happy to present the first session on this module. So I'll be talking on community-acquired pneumonia. I do not have any disclosures. So the objectives of this presentation will be to understand what is community-acquired pneumonia, its clinical presentation, the important differential diagnosis, diagnostic approaches for in community-acquired pneumonia, treatment strategies, and we will also discuss about the principle of de-escalation, appropriate duration, and IV to oral switch. So to begin with, pneumonia is an acute infection of the pulmonary parenchyma, and it is categorized into three. There is community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-acquired pneumonia. Community-acquired pneumonia is the one which is acquired in the community. A hospital-acquired pneumonia, it is acquired after 48 hours of hospital admission, and ventilator-acquired pneumonia, it's acquired after 48 hours of an endotracheal intubation. So in this presentation, we will be focusing only on community-acquired pneumonia. And community-acquired pneumonia can present in many ways. It includes respiratory symptoms such as cough, dyspnea, pleuritic chest pain, as well as systemic symptoms such as fever, chills, fatigue, malaise, anorexia, and so on. So community-acquired pneumonia is one of the leading cause of sepsis, as we know, and also so thus the patient may also present with symptoms like altered sensorium, hypotension, and organ dysfunction as well. And community-acquired, there are different other non-infectious causes which can mimic community-acquired pneumonia, and it includes congestive heart failure with pulmonary edema, pulmonary embolism, pulmonary hemorrhage, lung cancer, vasculitis, interstitial lung diseases, etc. And moving on to the diagnostic approaches in community-acquired pneumonia, there are three main areas, that is radiology, microbiology, and biomarkers. Radiology includes chest X-ray and CT imaging. Microbiology, it is used to detect the pathogen. It is the microbiological cultures are sent as per the severity and also according to the exposure risk. And it includes blood cultures, sputum gram stain and culture, urinary antigen test, which is used for streptococcus pneumoniae, Legionella, etc. BAL culture, that is bronchoalveolar lavage culture, which is used to find which is used to find out the potential pathogen. And also there are different multiplex molecular assays. For example, is the BioFire Filmari panel, Filmari Pneumonia panel, and Pneumonia Plus panel. And also we have different other nasopharyngeal swab tests which are used for identification of several viral pathogens such as COVID and influenza. The biomarkers include CRP and procalcitonin. And coming to the severity assessment tool, there are two major severity assessment tools which are used, and it is Pneumonia Severity Index and Curb 65 scoring system. These tools are actually used to identify the site of care. That means whether a patient has to be managed as inpatient or outpatient. Coming to Pneumonia Severity Index, it has a different criteria including demographic factors, coexisting illness, physical examination findings, laboratory and radiographic findings. And based upon the scores obtained, there are 5 classes. And if the score is less than 70 points, outpatient care is recommended. If the score is between 71 to 90 points, an observational stay is recommended less than 23 hours. If the point is more than 90 points, an inpatient care is recommended. Now, coming to the CURB 65 score, it has 5 criteria, that is confusion, urea more than 7 mol per liter, respiratory rate more than 30 breaths per minute, blood pressure less than 90/60, and age more than 65 years. Each of the criteria is assigned a point of 1, and if the score is less than 1 or a 0, the patient can be managed as an outpatient. If the score is 2 or more, then inpatient care is recommended. So as I already mentioned, PSI as well as CURB 65 scoring systems are used for determining whether there is an indication for inpatient or outpatient care. And coming to ICU admission, there is another criteria which is used. It is called as the IDSA ATS severity criteria. This is the most common criteria which is used. And it includes 2 major criteria and 8 minor criteria. The major criteria are septic shock requiring vasopressor support, requirement for mechanical ventilation, and minor criteria includes altered mental status, hypotension, hypothermia, respiratory rate more than 30, PaO2 to FiO2 ratio less than or equal to 250, blood urea nitrogen more than 20, leukocyte count less than 4,000, platelet count less than 1 lakh, and multilobular infiltrates. If a patient satisfies 1 major criteria or 3 minor criteria, it warrants ICU admission. Coming to the microbiology part, the most common causes of community-acquired pneumonia are classified into 3. That is, it can be caused by atypical bacteria, and also respiratory viruses. The typical bacteria includes strep pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, strep pyogenes, Enterobacteriaceae, and anaerobes. And among those highlighted in violet, those highlighted in purple are the gram-positive ones. And next is the atypical one. Atypical ones are those which are intrinsically resistant to beta-lactams, and they cannot be visualized using the usual gram stain or cannot be cultured using the traditional method. And it includes Legionella species, Mycoplasma pneumoniae, Chlamydia psittaci. And now coming to the respiratory viruses, it includes influenza A, B, SARS-CoV viruses, other coronavirus, rhinovirus, parainfluenza virus, adenoviruses, RSV, human metapneumovirus, human Boca viruses, etc. And among all these pathogens, the most common cause of community-acquired pneumonia is strep pneumonia. So these are the risk factors and the suspected pathogens for community-acquired pneumonia. So if a patient reports aspiration, then gram-negative enteric pathogens such as E. coli or Klebsiella pneumonia and oral anaerobes is to be suspected. In lung abscess, community-acquired MRSA, oral anaerobes, Mycobacterium tuberculosis, fungus, etc., is to be suspected. In structural lung disease, such as in COPD, bronchiectasis, etc., Pseudomonas aeruginosa, Burkholderia cepacia, and Staph aureus are the possibilities. In HIV as well and other immunocompromised patients, they can have a lot of other like pathogens such as fungi, which includes pneumocystitis, girovacea, cryptococcus, histoplasma, aspergillosis, etc. And if a patient is a resident in Southeast and East Asia or reports a history of travel to these areas with exposure to soil, then Burkholderia pseudomallei is a possibility. Burkholderia pseudomallei is the pathogen which causes an infection called as melioidosis. If the patient reports exposure to contaminated water, Legionella as a possibility, and exposure to birds as a risk factor for Chlamydia psittaci infection. So these are the risk factors for MRSA and Pseudomonas aeruginosa. So a prior infection, non-colonization, recent hospitalization or IV antibiotic use in the prior 3 months, immunosuppression. These are the common risk factors for MRSA and Pseudomonas aeruginosa. Recent influenza-like illness, necrotizing or cavitary pneumonia, empyema are also specific risk factors for MRSA, and specific risk factors for Pseudomonas are COPD and other structural lung diseases. Now moving on to the treatment part. So let us first discuss about the empirical therapy in outpatients. So I'll be discussing the IDSA ATS guideline recommendation. So in a patient who is healthy without any comorbidity, age less than 65 years and with no recent antibiotic use, the IDSA ATS recommendation is amoxicillin 1 gram TDS. Another option is doxycycline, but the quality of evidence for that recommendation is actually low. An ICMR recommendation in this particular category, in this particular group of people is amoxicillin clavulanic acid. And also, if a patient is having any comorbidity with age more than 65 years with and also with recent antibiotic use, the recommended empiric therapy is amoxicillin clavulanic acid with azithromycin or doxycycline. And alternatively, if a patient reports true allergy to penicillin, cefpodoxime or cefuroxime can be used. The duration of therapy is for 5 days, and in case of azithromycin, it can be stopped in 3 days due to its longer T-half. And in the treatment of community-acquired bacterial pneumonia, it is also important to rule out the viral causes such as the influenza and COVID. Let us move on to a case. So here is a 66-year-old male patient who is a non-case of COPD and diabetes mellitus. He presented with complaints of fever since 2 days associated with cough, generalized tiredness, and reported a history of left lower limb cellulitis 1 month back and had taken IV antibiotics for that. On examination, patient was found to be conscious, oriented, SpO2 was 94% in room air, and BP was normal. Counts and CRP were elevated. Expert-co flu RSV was negative. Expert-co flu RSV, it is a PCR test which is used to detect COVID, influenza, and RSV. So that was found to be negative. Chest X-ray was showing a right lower zone consolidation, and and the pneumonia severity index score was calculated to be 111. It belongs to class 4, so the patient was admitted in ward. Now, which is the most appropriate treatment regimen for this patient? So let us look at the empirical therapy option for inpatient. In inpatients, it is recommended that the antibiotics should be initiated within 4 hours for patients admitted to wards and within 1 hour for patients in septic shock. This 1 hour is called as the golden hour in patients who are in sepsis. Recommendation is to start on IV antibiotics initially, and later when the patient is clinically stable, an oral switch can be made. And the regimen recommended is ceftriaxone with azithromycin or doxycycline. Alternatively, amoxiclav 1.2 gram TDS with azithromycin or doxycycline can also be used. But also, if a patient reports any risk factor for MRSA, it is recommended to add anti-MRSA agents such as vancomycin, linezolid, or teicoplanin. And in suspicion of Pseudomonas aeruginosa, anti-pseudomonal agents such as piperacillin, tazobactam, cefepime, ceftazidime, meropenem, imipenem, aztreonam is also recommended. In suspected aspiration pneumonia, the guidelines, the ATS IDC guidelines recommends against routinely adding additional antimicrobial coverage unless there is lung abscess or empyema. And do not routinely add adjunctive corticosteroids. Corticosteroids can be added if there is shock refractory to fluid resuscitation and vasopressor support. So going back to our case, here our patient is a 66-year-old male who is a non-case of COPD and DM. and also reports recent hospitalization with IV antibiotic use. So this is a clear indication for empirical therapy with MRSA as well as Pseudomonas aeruginosa, because there are risk factors for MRSA as well as Pseudomonas aeruginosa. So, but here the patient was actually started on cephalosporin sulbactam, which will cover Pseudomonas, and doxycycline to cover for atypical. On day 2, patient was febrile, conscious oriented, hemodynamically stable, but blood cultures were growing 2 bottles of GPC. So teicoplanin was added to cover for MRSA and doxycycline was stopped. Next day, her patient was found to be febrile, conscious, hemodynamically stable. Total count decreased to 15,900 and CRP decreased to 154. This is the blood culture of the patient, which is shown here. And you can see that blood culture is growing Staphylococcus aureus, which is resistant to penicillin. And also you can see it is resistant to cloxacillin. So such a strain is called as the MRSA, that is the methicillin resistant Staphylococcus aureus. Here the patient's blood as well as sputum cultures were growing a methicillin resistant Staph aureus, and echo was done for this patient, which was found to be normal. Here, echo is actually indicated in this patient to rule out infective endocarditis, because methicillin resistant Staph aureus is a highly virulent pathogen and it can cause infective endocarditis. It is the most common cause of infective endocarditis. That is why echo was done in this patient in order to rule out infective endocarditis. Now the plan was to continue teicoplanin for 2 weeks. Here it is an uncomplicated Staph aureus bacteremia, uncomplicated because there is no metastasis to other locations. So in an uncomplicated Staph aureus bacteremia, the minimum recommended duration is 2 weeks. So we recommended teicoplanin for 2 weeks. Chlorhexidine bath and piperazine ointment to apply intranasally was also recommended, and this is for the purpose of decolonization of MRSA. Again, in MRSA infections, a repeat blood culture is also recommended to look for clearance. And we suggested do a transesophageal echo to rule out infective endocarditis if MRSA infection persists in the repeat blood culture. On day 6, patient was symptomatically better with no fever, hence was discharged on injection teicoplanin. And 1 week later, he was reviewed in the OPD. Blood cultures, the repeat blood cultures were negative. So an oral switch was made to tab linezolid 600 mg BT. So that is the first case. Now, going to our second case, this is a 75-year-old female patient who is a non-case of COPD, CADC, KD, and DM. Who presented with complaints of fever, shortness of breath, and cough, and also had recent admission with COPD exacerbation. The patient was conscious oriented and vitals were all stable. Counts were elevated, CRP 51.5, procal was 40. Again, in this patient also expert flu RSV was done, that was found to be negative. Chest X-ray was showing a bilateral mild pleural effusion. So here you can see again there is risk factor for Pseudomonas as well as MRSA. So the empirically he was started on piperacillin tazobactam to cover for Pseudomonas as well, and teicoplanin to cover for MRSA. On day 2, patient was febrile, hemodynamically stable. Again, blood cultures were growing 2 bottles of GPs. So the same antibiotics were continued. On day 6, cough reduced. Patient was febrile and had no fresh complaints. Also, the counts reduced from 36,000 to 5,500, and the blood cultures were growing sensitive strain of Streptococcus pneumonia. Now, which is the most appropriate treatment for this patient? So here is a list of organisms and the preferred antimicrobials to cover them. So for Streptococcus pneumoniae, amoxicillin can be used if it is found susceptible, or otherwise ceftriaxone or cefotaxime is the preferred antimicrobial. In Haemophilus influenzae, amoxicillin, second or third generation cephalosporin can be used. In atypicals such as Mycoplasma, Chlamydia, and Legionella, macrolide, doxycycline, or fluoroquinolones are the options. Chlamydia psittaci infection, doxycycline and macrolide is the option. In Staphylococcus aureus infection, which is methicillin sensitive, the drug of choice are cloxacillin, flucloxacillin, and cefazolin. And in MRSA infection, the drug of choice are vancomycin, linezolid, teicoplanin, and cotrimoxazole. In infections with Enterobacteriaceae, the drug of choice is third generation cephalosporins or beta-lactam, beta-lactamase inhibitors such as piperacillin, tazobactam, or cefoperazone sulbactam. But if the organism is an ESBL producer, ESBL is extended spectrum beta-lactamase, which means that the organism will be resistant to third generation cephalosporins such as ceftriaxone and will be susceptible to beta-lactam, beta-lactamase inhibitors. In that case, even if it is sensitive to beta-lactam, beta-lactamase inhibitors, the treatment of choice is carbapenems, and this is according to the Merino trial. And for Pseudomonas aeruginosa infection, anti-pseudomonal beta-lactams such as piperacillin, tazobactam, cefepime, ceftazidime, meropenem are the option. Other options include fluoroquinolones and aminoglycosides. For anaerobic coverage, beta-lactam, beta-lactamase inhibitors can be used, or otherwise clindamycin and carbapenems will also cover for anaerobes. In Burkholderia pseudomela infection, ceftazidime, carbapenem, fluoroquinolones, and cotrimoxazole is the targeted therapy. And in influenza virus infection, oseltamivir is the antiviral drug which is used. And if bacterial co-infection is suspected, an empirical antibiotic can also be started. So going back to our case, here the blood cultures are growing pan-sensitive streptococcus pneumonia. So piperacillin, tazobactam as well as teicoplanin was stopped for this patient and was started on ceftriaxone 2 gram OD. Day 7, patient was clinically better and was discharged on injection ceftriaxone 2 gram IV OD. Also, we advised pneumococcal vaccination, that is PCV 13, followed by PPSV 23 1 year later. So, one thing to note here is that prevention is also an important strategy to consider. Here we have vaccinations against pneumococcal as well as for influenza. For influenza, it is annual vaccination, and for pneumococcal vaccination is actually indicated for all patients above 5 years. And in those patients, the regime is PCV 13. PCV is pneumococcal conjugate vaccine 13, followed by PPSV 23. PPSV 23 is pneumococcal polysaccharide vaccine 23, 1 year later. And also, pneumococcal vaccination is recommended in patients who are immunocompromised, who have splenic dysfunction, and who have chronic heart, lung, and liver diseases. In that case, the schedule is PCV 13 followed by PPSV 23, 8 weeks later. So that is the prevention strategy. Now, coming to another case, here we have a 35-year-old female who, without any comorbidity, complains of right-sided hypochondrium pain, epigastric pain, chest pain for 3 days associated with shortness of breath and cough. On examination, patient was conscious oriented, SpO2 was 99% in room air, blood pressure was 140/70. Total counts were normal, CRP was 50.8. Cardiac markers were negative. Again, expert curve flu RSV was also negative. Chest X-ray was showing right minimal pleural effusion. So here you can see that this patient is a young male without any comorbidity. So there is no risk factor for Pseudomonas or MRSA. So the patient was empirically started on ceftriaxone 2 gram OD and doxycycline 100 mg BD. On day 2, patient was conscious, agitated, hemodynamically stable, complaints of severe right hypochondrial pain. So the antibiotics were escalated to piperacillin, tazobactam, and doxycycline was continued. On day 3, again, patient had persisting chest pain and had complaints of breathing difficulty, generalized tiredness, and vitals were stable. So CTPA was done to rule out pulmonary embolism, and it was negative. On day 6, patient had complaints of chest pain associated with exertional dyspnea. The saturation was 90% in room air. BP was 110/80. Chest X-ray was showing worsening of upper and middle parapneumonic effusion. Counts increased, CRP increased. Patient was initiated on NIV. FiO2 requirement was 60%. Then the patient was shifted to MDICU, and from there, antibiotics were escalated to meropenem, and doxycycline was continued. On that day, mycoplasma, PCR, and IgM were sent. On day 9, patient was clinically better, was de-escalated to ceftriaxone, and doxycycline was continued. He was shifted out to room, and mycoplasma PCR was not detected. On day 10, again, patient had fever. Mycoplasma IgM came out to be positive. So, in order to cover for mycoplasma, levofloxacin 750 mg was added to the regimen. On day 14, patient was stable afebrile and he was discharged on tab levofloxacin 750 mg. So now we'll move on to another important aspect, that is IV to oral switch. IV to oral switch, you have to consider if a patient is improving clinically, if the patient is hemodynamically stable and have normal functioning GI tract. In patients who were treated with ceftriaxone or cefotaxime with macrolide combination, then the recommended oral regimen is amoxicillin or amoxiclav or cefpodoxime with azithromycin or doxycycline. And in patients who were treated with IV fluoroquinolones, oral levofloxacin or moxifloxacin is the treatment option. Now, coming to the duration of therapy, the IDSA recommended duration is minimum 5 days, and antibiotics can be stopped if the patient is febrile for more than 40 to 78 hours, 72 hours without any oxygen requirement, and if there is resolution of tachycardia, tachypnea, and hypotension. Also, serial decrease in procalcitonin may be used to support discontinuation of antibiotics. In influenza, the treatment is the antiviral which is used is oseltamivir, and the duration is for 5 days. It has to be started in less than 48 hours from symptom onset, and irrespective of, regardless of the presentation time, oseltamivir is indicated for all patients who are hospitalized. Extended therapy is needed for extrapulmonary infection and infections with MRSA, Pseudomonas aeruginosa, Legionella, Barcolera, Pseudomyeli, fungus, etc. And it is also required in necrotizing pneumonia, empyema, or lung abscess. In complicated parapneumonic effusion, again, a longer course of antibiotic is required along with adequate source control in the form of drainage. So, summarizing my presentation, CAP is defined as an acute infection of the lung, uh, and the diagnosis involves clinical features, radiology, and microbiology. Empiric therapy depends upon the severity and comorbidities. In outpatients who are low risk, that means less than 65 years of age without any comorbidity and recent antibiotic use, the regimen recommended is amoxicillin 1 gram TDS. And in those with comorbidities more than 65 years of age, and with recent antibiotic use, the regimen recommended is amoxiclav with doxycycline or azithromycin. For inpatients, recommended regimen is IV ceftriaxone with azithromycin or doxycycline. Add anti-MRSA agents and anti-pseudomonal agents if risk factors are present. IV to oral switch is appropriate once the patient is stable and tolerates oral intake. Minimum duration of treatment is 5 days, and if the patient is febrile for more than 48 hours and clinically stable. And prevention include pneumococcal and annual influenza vaccination. So these are the references. So that's all about my presentation. Thank you. And I'm ready to take any question.
Okay. Thank you so much, Krishna, for such an insightful and informative session on community acute pneumonia. I think your expertise and practical insights is adding a lot of great value to our current understanding of this topic. I was wondering why, in the case, I mean, the third case that Mycoplasma PCR was positive and IgM was negative, or was it the opposite?
Yeah. See, here you can see that in third case, Mycoplasma PCR was actually sent on day 6. So PCR, it detects the bacterial DNA, while which will be high early in the infection. So by day 6, the bacterial load in the upper respiratory tract might have come down. That might be the reason why it came out to be negative. But in case of IgM, IgM antibodies starts appearing around 5 to 7 days after the infection. So on day 6, that is the peak time. So that might be the reason why it came out to be positive, and PCR was negative.
Okay, so that could be possibly a difference in the timing of infection.
Yes.
Yeah,
Yes.
got it. Thank you. So, thank you once again for this wonderful session. And I also thank all the viewers who are listening to our session today. So, your continuous support encourage us to keep bringing more and more advanced and impactful section like this through ID Forum. So this day marked the beginning of our advanced module series in ID Forum. So we are so excited seeing you in the upcoming sessions also. Until then, stay curious, keep learning, keep all the takeaways in the mind. Have a great day, everyone. Thank you. Thanks a
Great
lot.
day.